There are times when I've had discussions with people about the fact that my background profession is in occupational therapy, that they'll ask me for some examples as to the kinds of cases or clients or situations that I've been involved in. And um, one of the services that I gained quite a lot of experience in has been of a lot of interest, and that is the whole area of coma stimulation. So in this little video, I thought I would share some information that might be useful for you, either if you're a student or you're an occupational therapist and you're finding yourself starting to work in an area that has some comatized patients, or if you're the parent or a relative of somebody who's in a coma. Firstly, I would say I'm very sorry if you do have a relative who's in a coma. It's a challenging situation. We're going to get into a lot of tips that could be of benefit for you. Before we do so, let me introduce myself. I'm Shoshana Shear. I have a background in occupational therapy. I was working quite actively in occupational therapy for about 30 years, and I've moved on to writing books, creating videos, creating certain other products, and doing quite a lot with my art. So I'm also an artist and a published author. And my book that you'll see coming up on the screen, Healing Your Life Through Activity, does have a snippet about coma stimulation. I'm considering writing a little bit more on the topic. I did at one stage consider writing a full book, but my life has gone in other directions and I haven't done sufficient research or kept up to date with all the information to be able to write a book. Maybe I will, if there's enough need, do put a comment or a question in the comments below, and I'll be happy to consider doing so. In the meantime, I'm working on a much shorter, perhaps an ebook, perhaps a handout. You can let me know as well which you would find more useful. So without further ado, let's get on to some tips that would be of benefit for you if you find that you encounter somebody who is unfortunately gone unconscious and they're in a coma. I have quite a lot of information to share with you. This time I haven't counted it, so please don't hold me to whether it's 10 tips or 12 tips. I'm not counting it because I don't always follow along with the number as I do the video. The first thing that I want to say is to share a couple of stories, because quite often if somebody comes into hospital and they're unconscious, the first interaction that a parent or a relative will have with the doctor and the medical team, it could be a little bit overwhelming. It usually is very overwhelming, and sometimes the prognosis and the information given from the medical staff is not so positive. There are times that if a patient has come in with a severe head injury, for example, that a parent might receive very devastating news in wording that could be very difficult to hear. And I want to encourage you and say there's a lot to health and to the human being that goes beyond science. Keep in mind that we're not just a body, we're souls within a body. And I'll get to a couple of bits of information as to why and how that is important when dealing with somebody who is unconscious. But I could just share a couple of stories without giving too much information, but some cases that I worked with in some of the hospitals that I worked with, and I was involved in coma stimulation. Sometimes, as I say, the prognosis that the doctors have given has been very harsh, very limiting. They don't have much hope that the patient would regain consciousness or even be able to become functional again. Sometimes they'll speak of a patient potentially being in a vegetative state. We'll get to that in a little bit when we cover some terms that are important for you to know. Sometimes a situation will arise when a doctor will say, we're not getting sufficient response from this patient, we're going to be stopping active management. And what I want to say to you from the outset, the outcome of whether your your relative or your friend, whoever it is that you come in contact with who's unconscious, the outcome is not in in the hands of any of the medical staff. Although we all have to do, anybody of the medical team has to do their job, and it's very important, and their work is life-saving. Keep in mind there is a bigger healer, a bigger doctor, and that's God, who's in charge of us and who has the power. And I've seen it, miracles happen many, many times, that people have come out of a coma and been able to regain function to a level that, contrary to doctors thinking they might never survive or never regain consciousness, they've even gone to return to school or return to being quite active members of society again. Not on the same level as they were, but still functioning pretty. Most people might look at them and not know unless they were told that something had happened. There are also situations where a patient might have been, where doctors might have stopped active management, and despite everything, the patient regained consciousness. It could be 8 months later, it could be 8 weeks later, 8 months later, a couple of years later. There are stories that have been shared. I've watched a colleague of mine treating a patient that they'd stopped active management, and then he regained consciousness, and the turmoil and the frustration that this child went through. Or in another situation where the team jokingly tried to bribe a comatose or a semi-comatose patient into speaking, giving up hope and turning their backs, only to have the patient surprise them and have some quite harsh words to say towards the medical team that was moving on to the bed, the ward round that was moving on to the next patient. And yes, surprises happen. So keep in mind that as much as healthcare has a part to play, there is more to the picture. And I want you to please maintain your hope and put in your tefillah, because tefillah is Hebrew for prayer. Prayer is extremely powerful, it's extremely important, and to keep in mind that miracles do happen, and God is bigger than any of the doctors. So with that little bit of introduction, the first thing I want to mention is somebody who's unconscious usually would come into either the emergency room, or will usually go into the emergency room, and from there go into ICU. Sometimes they'll go into what's called high care, which means that the nursing staff are going to give a higher level of care and attention to that patient. They'll be kept right close to the nursing station so that the nurses can be able to offer a little bit more intensive intervention, but not at the same level as the ICU. They'd be more shifted into the ward. There's all sorts of reasoning. I don't know hospital management in all the different countries, but just keep in mind these terms that you would come to hear, which could be overwhelming. You might not want to know them, but ER is emergency room or trauma room in some countries. Then there's the ICU, and then there's the high care, and then obviously the rest of the ward, depending on how long the person has been in hospital, how long they've been in a coma for. Various policies come into play. So those are the rooms and the parts of the hospital that you'll come to get to know first. The next thing that I want to mention, and I'm putting an image up here, but it by no means represents all of the machines that somebody who's unconscious might be connected to. So the next thing is that all of the machines, the charts, the beeping, the sounds, everything that happens around somebody who's in a coma can be very daunting, very overwhelming, very off-putting for the family members. And the first thing I wanted to say to you is to ask the doctors or the nurses or either the occupational therapist or the physiotherapist to explain to you what these charts are, what these machines are, what they mean, what they're doing. Any questions that you have, feel free to ask the team and to become familiar, because there is information on those machines that can be valuable for you. For example, if you see the heart monitor and the blood pressure is changing, it might be that you need to now call the nurse, or perhaps press the bell, go and call for a doctor. When each of the different pieces of information and pieces of machinery is important for you to know about, this will all be explained to you by the team. Keep in mind that the team, when a person first comes into hospital, the team is extremely busy. They're busy with all sorts of other patients, and they're busy in trying to stabilize the patient as far as possible. So they often do not think of the patient's family, but the family is going to become a very important part of the rehabilitation process. So get to know what the machines are. If the doctors and the nurses are too busy, do ask either a physio or an occupational therapist, or ask to speak to one. And it's important that the occupational therapist get involved with working with somebody who's in a coma right from early on. Exactly when will depend on the level of the coma, on some details as to what other injuries might be involved. The doctor would be the person in charge of that. Quite often the doctor might not be aware about coma stimulation and the role of occupational therapy, which is the reason for this video, so that you can know to request that the doctor does refer to occupational therapy and bring an occupational therapist on board. We're going to get to the occupational therapist shortly. Firstly, I want to go to a few other pieces of information, and we'll come back to the occupational therapist and to coma stimulation, which is what I keep mentioning. The next thing that I want to mention is the coma scale. I've seen it used in two different formats. In the hospitals where I worked, we used the Glasgow coma scale, Glasgow coming from Scotland, obviously. And within the Glasgow coma scale, there are 3 different categories or areas of the body and the functioning that are monitored all the time. So there needs to be a score on each of those 3 groups. On each of those categories, there will be a score, and the lowest will be 1. If somebody doesn't have a 1 on any of those, they're entering into very scary territory. We're not going to be dealing with that right now. Speak to your medical staff as to what the meaning is of the Glasgow Coma Scale. There also is a Rancho level, which I haven't used at all. It wasn't used in the hospitals where I was working, but I have being in contact with a colleague of mine who was working in America. He always mentioned the Rancho levels. There is a slight difference between the two, but both of them work on a similar in a similar manner. The Glasgow Coma Scale basically, firstly, is going to look at what kind of eye movements the person in a coma has, if any. Does the pupil respond to light? Is there movement of the eye? If they speak to the person, can you get the person to close or open their eye in response to either a command or having their name said? Is there any kind of reaction from the eye? So all of these things the doctor will be monitoring, and that's the one category, is what are the eye movements. The next category is all to do with the movements of the body, whether there's just a reflex reaction, whether there's a movement of any of the limbs, any part of the body in response to either their name being called or a certain instruction. Can they do what's requested of them, or do they have any voluntary or involuntary movements? What movements of the body has are all within the second category. And the third category is related to spoken verbal interaction that a person has, which starts off with sounds and it moves to forming kinds of words. It will be different as to if somebody has had certain area of the brain that's been affected that's related to speech. There could be speech problems involved, but those are all things that would be important. Also keep in mind, if somebody becomes intubated, that's one of the terms I should have put down, but I'll get to terms in a few minutes. If somebody is needing to breathe with assistance of a machine, either through the mouth or through their trachea, they're not going to have the speech, because that speech it's impossible to be talking if there's something in your mouth for breathing purposes. So the doctors will have other ways in which they'll be monitoring the person all the time. But that's very important to keep in mind. And the reason it's important to keep in mind what the level of the coma scale is of the person is, if somebody is unconscious, if somebody is in a comatose state, they're unconscious, they're semi-conscious, they're vegetable, all of these terms you might start to hear mentioned. But basically what it comes down to is what the level of the coma scale is. And depending on the level of the coma scale will have an indication as to what the potential for recovery is, what the potential for your interacting with the person, what ways you should interact with this relative of yours, what kinds of things therapists can do. There's all sorts of important information from that coma scale. So I'm not going to give you very much more than that. I do recommend that you ask your physio occupational therapist, the doctor or the nurse, to explain it in more detail, depending on which level they use, the Glasgow coma scale or the Rancho level, and where your relative is situated. But keep in mind that if somebody's in a coma, there are still certain senses that are working. One of those is the sense of hearing, and that's extremely important for you to know. Also, the sense of smell becomes very important. We're going to come to those in a few minutes. Let's get back to the terms that are important for you. The first one is the term of coma, and I've mentioned variations of that: semi-coma, unconscious, vegetable state. All of these different terms that are thrown around, these are all related to a coma, and it basically means that somebody who's not able to respond to commands, to interact in a normal manner. I'll be putting up here a definition for you of a coma that you can read. I'll give you a minute or so to read that. The next term that's important for you to learn and to know is the term edema, which is something that's thrown around in the medical world related to all sorts of different things. Edema basically means inflammation. That's going to be important for one of the potential areas of intervention, either for the occupational therapist, perhaps for the physio, is the whole area related to edema. You get quite often somebody who comes into the hospital will have swelling around the face, inflammation. There could be swelling in other parts of the body, quite often in the hands, quite often in the legs. That brings us to the next three related terms, which you might hear about by either the OT or the physio, and that would be the passive movements, the active movements, and facilitated movements. So passive movements are basically of the therapist. The passive movements are usually carried out by the therapist, and they will be assisting the patient to maintain certain range of movement by moving the limb or by moving a part of the body on behalf of the patient in certain directions to maintain movement, to maintain range of movement, and also to help with the circulation. That's passive movement, which is extremely important. Some of it is carried out by the OT, some of it by the physio. It's important to make sure that anybody who's in a coma is receiving a certain amount of passive movements. The next one is active movements, which would be that the person is able to start to move their arm or their eyes or any part of the body that they can actively move themselves. and there's a difference as to whether they're moving it themselves independently of your saying anything, or whether they respond to your saying, please open your eyes for me, can you lift your hand, can you, whatever the command is. And then the next one that we're going to be moving on to is all related to coma stimulation. So coma stimulation is carried out by the occupational therapist. I would recommend that the occupational therapist is also experienced with or even certified in either neurodevelopmental techniques or sensory integration, or both. They both have a part to play. Coma stimulation is quite controversial, but it's very important, and I've seen amazing outcomes happen from those people who do receive coma stimulation while they're in the hospital, while they're in a coma. The first tip that I would give related to that is that positioning of somebody who's in a coma while they're in their bed. Obviously, sometimes they also start to move a person out of the bed and into a chair next to the bed for ways to try to stimulate the person, to encourage the person to regain consciousness. There's certain reasons as to why being in the sitting position is important, but the positioning of the body as a whole is extremely important. And one of the reasons is to prevent contractions. So even if your relative is in a situation where unfortunately they're not responding too well, and the doctors say they're considering stopping active management, I would encourage you to request that they at least still have the OT and the physio, or either teaching the nurses or monitoring some kind of way in which positioning still is maintained. And the reason for that is that if 8 months later, 8 weeks later, whatever the time period is, if the person then regains consciousness and nothing has been done to maintain that positioning, to maintain the range of movement, then rehabilitation becomes quite complicated, because you're dealing now with contractures that have developed in various parts of the body. It could be in the elbows, for example. Somebody might be in this kind of a position, and there'll be tightness. We call it contractures because that muscle becomes so tense that it's contracted. It's no longer able to be stretched out in an easy manner. There are techniques that the therapist would do, but sometimes it'll get to the doctors having to do surgery to release those muscles, or that the person remains in a develops certain deformity, which is a pity, because positioning could be done to prevent that. And that's very important for both the arms, for the feet, for maintaining the foot position, that we don't get what's called, that your relative does not develop what's called a foot drop, that they're not able to lift their foot, and they're walking later on, if they do regain consciousness and they try to begin to walk or to stand, walking becomes complicated, and they might need splints or special boots or various other things further down the road. And all of that can be prevented if the right positioning is carried out. I'm not going to be teaching you what the positioning is, because that's specific to each patient, but do ask, if you do not yet have an occupational therapist involved, do request occupational therapy. They will be working together with the nursing staff. They might put up a chart. They might teach you certain things to be done, either with the pillows or bringing in certain shoes for the person to wear for certain hours of the day. There are a number of things that they might be doing and be involved in. So positioning is extremely important. The next tip that I would give you is to keep in mind that somebody who's unconscious does have a certain amount of time that they can be able to pay attention to what's going on around them. The problem is that there's so many noises that happen in the hospital situation that the brain kind of tunes out, and that the amount of time to stimulate somebody is very short. So if you're speaking to your relative, if you want to read to them, if you're wanting to put on music, something that they quite often do is they'll want to put the radio on. And I want to encourage you to make sure that any active way to trying to use sound to stimulate and to try and encourage your relative to come back to this world to be used for a maximum of 15 minutes. Your occupational therapist can explain to you why and any details related to that, but basically don't put on a radio for longer than 15 minutes or music or any way that you're having some sound around for longer than 15 minutes, because the brain is going to tune out and it's going to no longer have the benefit that you're wanting. Also, if you do have music, try to have some kind of a variety as to what type of music you're using. What kind of variety is necessary for your relative would be dependent on your situation, and I would encourage you again to speak to the occupational therapist. He or she will guide you as to what kind of music to use, what kinds of words to use, what kind of topics to talk about. The way that you speak to your relative is going to be extremely important. To use short sentences, to structure your sentences in a specific manner, and all of that your occupational therapist would be able to guide you with. The next tip related to that is to make sure that there are only 2 visitors next to the bed of somebody who's unconscious at any time. More than that becomes too overwhelming for the person, and you could be delaying their ability to come out of the coma if you're going to be bombarding them with a whole lot of people. I also want to say, please keep discussions around the bed to be directed to the person who's in a coma, and to be on positive comments. Keep away from topics that would be depressing for them. Keep away from information that's unrelated or unnecessary. So, for example, if you are sitting at the bedside of your relative who's in a coma, and in comes in a relative of yours that you haven't seen for a period of time, and you start having a chit-chat between you with that relative, rather take that chit-chat out somewhere else, because that interaction could be distracting and distressing for the person, and the purpose of your visit would be to help to encourage, to be there, to be supportive to the person who's there in the bed. Also, you can sit quietly and read Tehillim, Psalms. You could read some encouraging pieces to them. You could have some conversation that you've recorded from perhaps at mealtime. Let's say, for example, that the person who's in the bed is a female, and you're wanting to say to her that, hello, this is the meal, whatever, whether it's breakfast, whether it's lunch, whether it's supper, this is the meal that we're having together, this is the day that it's happening. Put in all the information that you can to help to orient the person, and have some kind of a positive message, some kind of information to help to keep them connected with this world. So you could say, for example, we're all sitting around the table. You can say who the people are. Each person can just quickly say hello and a greeting to the person. Keep it obviously short, as we said, and then say something about Johnny made the lunch today, or we made Sammy's favorite dish, something that would be of interest and keep the person connected to the family. That's quite important. I mentioned the fact that certain senses are going to be still functioning all the time. There's a lot that we learn from the work of people like, for example, Elizabeth Kubler-Ross, who teaches how somebody who's going through a death process, that the soul would lift out of the body. It goes in a certain journey. She talks a lot about this light at the end of the tunnel. There are times and ways in which you can be using that information to speak to your relative and to encourage them to come back to this world, to encourage them not to be distracted by that light, but to come back to your family. Tell them how much the person is needed. Tell them what value or what benefit they would be doing by continuing to live, how much you need them, how much you care about them, how much you would enjoy to do whatever together with them, whether it's sailing, whether it's going on a trip, whether it's writing a book together, whether it's reading a book together. Give them some kind of something that's encouraging. So you're relating all the time to things that are important to that person and not conversation that's unrelated to them at all, because that becomes too much for them. Something that's important is in today's time with technology is to find out from the nursing staff or from the doctor as to what extent you can have your smartphone with you. Sometimes certain phones and certain technology can interfere with the machinery around the patient. So find out what's possible, especially if you're recording a message that you want to play to your relative. Find out if there's any difficulty before you start doing so. So that's something that's important. I mentioned that if you do record a mealtime message, for example, to mention the date, to mention the time, actually orienting your friend or your relative is important every time that you come to the bedside and you make contact with them. Perhaps you touch them on the hand and you say to them, good morning, whatever their name is. Today is, say the day, say the date, say who it is, that it's not just a voice. Remind them who you are, remind them how you're connected with them, so you're constantly making a connection. If you're touching the hand, say to them, I'm touching now your left hand, or I'm touching your right hand. You could say something about the weather, certain things that help to keep them oriented and enable them to be connected to this world, to know what is the time, who is the person who's coming to them, what is the weather like, what are these things that are around them, because while they're in a coma can be a very confusing time for them. They're going to be losing track of time. So something else that I would recommend is to have a journal. I've prepared one which you'll find if you have a look on my Amazon Central. The link is in the notes below. You can have a look to the various journals that I've created. And one of them is a hospital visitors journal. And if you use that, you can write a short message with the date always. Say who it is who came to visit. Let them know something that's different, something about how you felt when you came to visit them, how you found them. Had the sweating gone down a little bit? Had you been happy to see a change that I don't know, some statistics had started to stabilize? Perhaps their blood pressure stabilized a bit. Perhaps they no longer needing a tube in their mouth and now they have the oxygen from a mask. Anything that you can find that's positive. So always try to keep on a positive, always try and give them hope. Try to let them know how important they are to you, what meaning they'd have to you. And also keep in mind, if for any reason they do slip on to the other world, that interaction is extremely important that they're having with you. So if there's any reason for you to be, perhaps you didn't tell them before how much you care about them or how much you love them, use this as an opportunity to tell them that. If there's been any difficulty, tell them you forgive them, tell them whatever they need to hear, that they can be at peace, that there can be peace between you. Sometimes that will help them to be at peace, that they'll move on in a peaceful manner, and sometimes that'll give them the encouragement to come back. Life and death is not in our hands, it's in the hands of the Creator, of the Master of the universe. But the way that we interact with the person is important, and it helps to continue that relationship And it helps us to stay focused and to know that there's more to life than what we're seeing. That I won't get into too much more, because this is a topic I could get into in another video. I'll leave that for now. But you can have more discussion either with your occupational therapist, or perhaps with whatever member of whichever place of worship you go to, a rabbi from a synagogue, if there's somebody, a clergy person related, a chaplain within the hospital, whatever's related to your faith. Do be in touch with them and discuss with them whatever concerns you have. The next little tip that I would say is, in today's modern times, there's such a concept as telehealth. The whole service of coma stimulation, quite a lot of it needs to be done in person by the therapist, his or herself. And so telehealth is not necessarily going to be involved, although there are one or two times in which it could be of benefit, and that is if the occupational therapist is already involved and working several times a week together with you and with your relative, and you've just arrived and you're needing to say to the therapist to ask a question, or perhaps the therapist on that particular day is not going into the ICU, or they've already been to the ICU, and you've noticed some kind of a change that you want to ask a question. For those kinds of situations, it can be very beneficial to link up through whichever program they permit in the hospital, to link up and to be able to see whether it's on WhatsApp, whether it's on Zoom, whether it's on Skype, to be able to interact with the therapist and to say to them, I've now seen that so-and-so's blinked, or they opened their eyes, or I showed them a picture and tears rolled down, and I just want to share this with you. You could take a picture on the spot if they allow you to have your smartphone, and show that to the therapist, because those kinds of pieces of information are very beneficial that the therapist can take then into their next session. So that's a little bit about telehealth. This is one situation in which intervention does need to be in person, because a lot of the techniques that are used are very hands-on. So that brings us to one of the next techniques, and that's related to the word edema. As I say, quite often you can find somebody who's in a coma could have swelling in various different parts of the body. There are certain techniques that an occupational therapist and or a physio would be using. If somebody has a hand injury, which it could be that they have a hand injury as well as a head injury, or as being in a coma, there's a technique called an edema drill, and there are ways in which an occupational therapist could be able to facilitate that happening, or they could do a related but different aspect, different technique called lymphatic massage, and this does require specific training. The occupational therapist might be trained in lymphatic drainage massage, or the physio would be doing that. But it's very important that somebody who has swelling, edema, inflammation, that they do receive that kind of a massage. Obviously, always under the supervision of the doctor. The next thing to keep in mind is that there are some alternative therapies that could be of benefit as well. The first one I would mention is acupuncture. Some physios are trained in acupuncture and acupressure, so you might get it from the physio. Sometimes an occupational therapist would also be trained or training in acupuncture or in acupressure, and there are certain parts of the body, especially on the big toe, that could be very valuable, very beneficial. Reflexology related to the acupuncture could sometimes be beneficial as well. Since the sense of smell is so important for somebody who's in a coma, some occupational therapists also train in the use of certain essential oils and using aromas and smells in order to stimulate the person to bring them out of their coma. It might be that in certain situations, if the OT is not as experienced with using different aromas, that an aromatherapist might be consulted. It's quite important to know, firstly, which types of smell your relative preferred or didn't like, and they can be used in different ways by the occupational therapist in the stimulation, but also to give that information if you do have somebody doing any kind of aromatherapy. In any of the alternative therapies, even with the occupational therapist, always needs to have the referral and the guidance and the okay from the doctor who's in charge and who is supervising or taking care of the patient. Also keep in mind that certain energy work, energy healing, Jinshinjutsu, even homeopathy at certain times can be of benefit. The simplest being rescue remedy, which could be of assistance. I'm not going to be telling you anything about the homeopathy. You'd have to make sure that the homeopath, that any remedy that's used, that there is a qualified homeopath who's administering that, and also that that's in agreement with the medical team. There are certain remedies, for example, arnica is wonderful for helping to reduce bruising and swelling, that inflammation, to help with healing, but what dosage would be used and whether it could be used and whether it's appropriate for your relative all depends on certain information that's up to the doctor and the homeopath to decide. So there are times when that could be of benefit, and obviously always to check out all the time as to what's the most suitable for the needs of your client. Something that I picked up with some of my clients is, especially once they come out of a coma, they quite often will say that the hardest detail for them being in a coma is the fact that their mouth becomes so dry and they're unable quite often to swallow, or they're not drinking fluids, so the lips becoming chapped and the tongue becoming dry. There's not very much that they can do about it, especially if their arms are not very mobile at the time. So what you can do about that is to, number one, to put Vaseline, either lip ice or Vaseline, onto the lips, always with the okay first of the nurse. The nurses also have some very interesting, they're not cotton swab kind of things that are, it's like almost like a lollipop, but or a sucker to an extent. It's a kind of a foam that's cool, that can be put on the end of a stick, that can be put onto the tongue, and it helps to just put that little bit of moisture into the mouth. Very important to do that with the okay of the OT and the nurses. They will have to show you how to do it, what to do, but that will help to alleviate that frustrating feeling that the person experiences when they're in a coma. One of the reasons for always checking as to what's being done is because if somebody has a swallowing problem, you can cause certain problems. So always be working along with your team. So with that, I want to once again give you encouragement to maintain the hope, to stay positive, to work with the team. If there isn't yet an occupational therapist involved, request from the doctor to refer to occupational therapy. Work together with the team, get to know the team, ask your questions, see how you can be involved in assisting in the rehabilitation process and in assisting your relative to come out of their coma. I wish you a lot of strength, and that you find the right team, that they all come together and they'll be able to assist you in your process. But this video is just giving you the information you know as to what to ask for. Coming to the end of this video now, I would like to encourage you that, once again, as I said at the beginning, this video is not a replacement for therapy in any way whatsoever. The tips that I've mentioned are nothing that you should be doing on your own. It always should be done under the guidance and the okay of the doctor, and with the referral to occupational therapy, that the occupational therapist would be doing the coma stimulation, and you'll be able to start to be aware of some of the things to participate in, or to get involved in, or to work together with the occupational therapist. The times that I have worked quite intensively with the family as well as the patient, the outcomes are so much better. So become a part of the team. You're an important part of the team. Share information as to what the person enjoyed, what was important to them, and all of that. The team will help you as to how to word that, how to use that to help to encourage them in their recovery process. So with that, I hope that this video has been of benefit to you. It's one that I've been grappling with for a long time as to what extent I should and I could give this information out. But these are tips of things that I've discovered along the way that often are problem areas. And once again, it's all to encourage you to get that OT and board, to make sure that there's a full team working with your relative, and not to give up hope, and not to sit back and think that life is over and the person will never be the same, or will never be a part of your family again. There are times when a person, as I say, comes out of their coma and surprises the doctors and returns to functional living even after having been in a coma. So I hope that that's given you some hope. I hope that that's given you some food for thought. It doesn't replace the reality of whatever you're going through. There's so much more that I could be talking about on this topic, but with that, I want to leave it up to you to put a comment in the comments below, to be in touch with your team and to talk to them, to open some conversations with them, and I wish you a lot of blessing. It's Shoshana Shia coming to you from Jerusalem. As I say, I'm an occupational therapist of background. I used to do coma stimulation. With that, I wish you a blessed day, and I look forward to seeing you in a different video.